Coming to the congenital dislocation. Congenital dislocation of the hip is more common than any other joint because posterior superiorly the strength of the acetabulum is not formed properly. That is the buttress, we can say. The buttress part of the acetabulum is not formed properly, so there can be the congenital dislocation of the foot that is seen, hip joint is seen. So the hypoplasia of the acetabulum and the femoral head is seen, where the head will move or slip upward into the gluteal region like this. In the radiograph you can see it has moved upwards into the gluteal region where the acetabulum is developmentally deficient here, that is posterior superiorly. When there is congenital dislocation, there is shortening of the limb that is seen, and the lateral rotation also is seen. The foot is externally rotated, and the shortening of the length of the limb can be noted by uneven skin folds on the thigh on both the legs. Asymmetrical skin folds can be seen, and neck shaft angle is exaggerated, it's more, so there can be coxa valga, and adduction is limited. So here in the radiograph you can very clearly see this is where the head is in position within the acetabular cavity, and this has moved up as there is no proper development of the acetabulum posterior superiorly. And the dislocation of the hip joint, normally the posterior dislocation is more common than the anterior dislocation. So here you can see it is the posterior dislocation. The head has moved towards the gluteal region from the acetabular fossa. So this is what is the acetabular normal hip joint here. This has displaced posteriorly. In this posterior dislocation, the sciatic nerve can be injured with the pressure of the head onto the sciatic nerve, and this is what is the anterior dislocation, where the head is seen within the obturator foramina here from the acetabular cavity. The head is seen dislocated onto the obturator foramina. So this occurs during forced abduction and the lateral rotation of the hip. So this anterior dislocation is not very common. The posterior dislocation is the common dislocation of the hip joint. So we can know by the position of the limb whether it is a fracture or dislocation. When there is fracture neck of the femur, as we said, there is shortening of the limb and lateral rotation, whereas in dislocation there is shortening of the limb but is medially rotated foot is seen. So this is the main characteristic feature in distinguishing the fracture from the dislocation. The osteoarthritis is a disease of old age where it is characterized by presence of all these osteophytes, which are phagocytic cells, and they are present on the articular ends, and they eat away, they narrow, they destroy the articular cartilage of both the acetabulum and the head of the femur, narrowing the joint space. So this is how the arthritic femoral head is seen. So when such type of condition occurs, there has to be hip replacement that has to be done. And there can be, because of this infection, there can be referred pain that is referred to the knee joint. The patient with the osteoarthritis of the hip joint will have pain in the knee joint also, because of the common nerve supply of these two joints, that is the femoral nerve and the anterior division of the apparatus nerve as well. So when this is being worn out, if there is osteoarthritic changes only of the head, only the head replacement is done, and that is called as hemiarthroplasty. Any hip replacement or any of the replacement of the joint, it is called arthroplasty. So when only the head is damaged and is replaced, it is called hemiarthroplasty. That is, only one part of the joint is replaced. When both the acetabulum and the head are damaged and both have to be replaced, then it is called as total hip replacement. So there can be the acetabular labrum tears, which can also lead to dislocation, because as we said, the labrum will tightly pack the head into the acetabular socket, that is the socket of the acetabular cavity. So when there is any damage to the acetabular labrum, then there can be dislocation and can be noted by MRI. And if something like that is seen, the torn labrum is sutured with anchor sutures. That is called as labral refixation, or debridement can be done. The run out part can be taken out and then it is repaired. So this is usually seen in the motor accidents and sports that require the regular rotation of the hip, that is like golf, soccer, hockey, football, ballet, the ballet dances. So in all these cases, the labral tears can be seen, and they are more common in women and are more common with the conditions of osteoarthritis and any other pathology of the hip joint. So surgical repair is done by orthoscopically, that is through the laparoscopically. The surgeon sees what he is doing. Refixation repair, that is a stitching of the torn tissue back together. Reconstruction is done where the damaged tissue is replaced by a healthy tissue from their own body or from a donor. A debridement is done where excess removal of the labral tissue is done. And aspiration of the hip joint is also seen in the infections that happen with the hip joint. So the aspirations are usually done to diagnose and assist the treatment of the joint disorders, like in arthritis and all, and in infections. And it can also be done to remove large collection of fluid around the joint when there is some pathology with the synovial membrane. And there can be bursitis, that is inflammation of the bursa, where the aspiration can be done from the inflamed bursa. So here you can see the needle is inserted about 2.5 centimeters lateral and distal to the point joining the inguinal ligament and the femoral artery. So the doctor will look for the pulsations of the femoral artery and go laterally and distally down to 0.5 centimeters and advance the needle about 5 centimeters medially and proximally into the joint. So this is usually done by putting a needle 5 centimeters below the anterior superior iliac spine, upward, backwards and medially. So that's how the aspiration of the knee joint is done to evaluate any joint infection or any arthritis, or to remove the excess collection of the fluid within the joint. And these are few tests that should be known by seeing the radiograph. Few of them. The Needletons line is an imaginary line that is drawn from ischial tuberosity to the anterior superior iliac spine of the pelvis of the same side. If the greater trochanter of the femur is palpated well above the line, then it is considered as dislocation of the hip or coxa vara. So the patient is made to lie on his sound side where the patient doesn't have pain on that side of the hip, and a line is drawn from the ischial tuberosity to the anterior superior iliac spine and palpated for the greater trochanter. If the greater trochanter is palpated above the line, then there is dislocation of the hip joint. A clear representation is the Shentons line in a radiograph, where it is the continuous curve that is formed by the upper border of the obturator foramen and the lower border of neck of the femur. This arch, which is represented here, upper border of the obturator foramen to the lower border of the neck of the femur. When there is discontinuity in this arch, that is, there is no correlation between the upper border of the obturator foramen to the lower border of the neck of the femur, it indicates there is dislocated hip. That can be very clearly seen with the radiograph. There are a few more lines that can be seen radiographically to come to a conclusion for the pathology of the hip joint. Where there is dislocation of the hip joint or not are the Hilgenrius sign, Perkins line and acetabular angle. When a point on both the acetabulum, the right and left, are taken and a line is drawn joining those two forms the Hilgenrius sign, where it passes through the triradiate cartilage of the acetabulum. The Perkins line is a perpendicular line that is drawn to the Hilgenrius line from the lateral margin of the ossified acetabular fossa, which usually coincides with the lateral margin of the femoral head. And the acetabular angle is the angle that is formed by the acetabulum to the Hilgenrius line. So when the head is seen within the acetabular angle, that is, when the head is above the Hilgenrius line and lateral to the Perkins line, it is seen in the acetabular angle. So when that is seen, it confirms the dislocated hip, and it also confirms the Shentons line not being accurate. So here you can very clearly see in this radiograph this is the Shentons line, and from point here and here the acetabulum, when a horizontal line is drawn, it is the L-genius line. From the outer border of the ossified acetabulum, when a line is drawn perpendicular to the L-genius line, it is the Perkins line, which also corresponds laterally to the head of the femur. And a line that is drawn across the acetabulum to the hernia's line is the acetabular angle. So when the head is seen lateral to the Perkins line and above the L-genius line, it shows the dislocated hip joint. So here you can very clearly see all the structures. This is the spine, where these are the lumbar vertebrae. This is the sacrum, the hip bone, the ilium part of it. This is the sacroiliac joint. This is the ischium. This is the pubis, acetabular cavity, head of the femur, neck of the femur, greater trochanter. This is the lesser trochanter, and the shaft. Yeah, this is the obturator foramina. This is the superior ramus of the pubis. This is the ischial tuberosity. So this is what you can see in the hip joint. The radiograph of the pelvis as well. Another surface anatomy that is important is the Baynes triangle, where the patient is made to lie on the dorsal position and a line is drawn vertically down from the anterior superior iliac spine, and another line is drawn from anterior superior iliac spine to the greater trochanter, and the third line is drawn joining the greater trochanter to the first line. So this forms the Baynes triangle. When there is diminution of the horizontal line when compared to the other side, that denotes the fracture of neck of the femur. When diminution of the line that is joining anterior superior iliac spine to the greater trochanter is seen, that indicates the anterior or the posterior dislocation of the hip joint. Another line of diagnostic importance is the Shoemakers line, where a line is drawn from the tip of the greater trochanter to the anterior superior iliac spine and is extended onto the abdomen. So the intersection of both the lines will be above the umbilicus. When there is dislocation of the hip joint, then the line will cross below the umbilicus. So when a line crosses below the umbilicus, that side denotes that there is dislocation of the hip on that side. So these are all the surface markings that will be useful for diagnosing the fracture of the hip or the dislocations of the hip. That's how the surface marking makes a very important part in anatomy. Thank you. Have a great day. Good day to all.